which is a continuing journey. It's not the end of the road by any means. And then a little bit about the leading edge, and I'm hoping the things I've selected from the leading edge will actually fit in very well with what the previous speakers talked about. But I'd also like to spend just a little bit of time talking about the opportunities for you in leadership, because the opportunities for you as a group of resident medical doctors are absolutely enormous. And in fact, we need you to be working with this improving system. So here's a quote to start. The original quote was, "A hospital is no place to be sick," but in fact, I've taken the liberty of putting in a health service. But interestingly, here's a comment from a guy who's a movie producer and a long time ago. So we're obviously on a journey of improvement for that sort of comment before. So a little bit by way of introduction. So here's a map of Australia. The best one I could find that actually had Tasmania on the bottom of it is actually the electoral boundaries, but just ignore that. And Sydney LHD is that little dot on the side, the black dot in the middle of the orange. It looks pretty small, but in fact, it's a fairly large area. The Australian health system has a Commonwealth state territory function, where the Commonwealth has key roles in governance and funding of health. And only recently has Australia gone back to the system, what we're calling episode funding or activity-based funding, which some of you will be very familiar with. So at some stage it may feel like the Commonwealth's role is predominantly about funding and the kinds of services we provide, but that's not where they're going to at the moment, or the directions they're taking. Local health districts, which are our current governance structure, have only been in place since July 2011, and it might sound like it's a long time, but constant restructure and constant reorganisation is actually one of the enemies of trying to get in place the kinds of change that we're talking about today. So the fact that we've actually got something that's in place for about 5 years now is really good. Unfortunately, there was a change to the way that our primary health networks were organised. So before 2015, Australia had something called Medicare Locals. And Medicare Locals were basically the way that general practitioners, who are still independent practitioners in Australia, would come together for a variety of different functions, and they also formed a relationship with local health districts. And at the time I was fortunate to be working with a local health district who had a Medicare local with the same geographical boundaries, a one-in-one relationship, and we were able to be very innovative in some of the things we do. The new primary health networks have got a broader brief in terms of community health services or community-based providers, and basically the general practitioner networks are there as well, but they're still finding their feet at the moment. I understand that's a different structure to what you're used to, but basically in Australia we're settling it down. There are differences between the states. So in New South Wales, the local health districts have a responsibility for the whole of the health services that are in their areas. That's the public health services. So it's not just hospitals, but it includes subacute facilities, mental health, community-based services, but also the response to public health, population health, health promotion in those areas as well. So New South Wales is very much about the whole of health type approach. In some of these states, the local health districts are much more centred on hospitals because that's the way their governance structures work. So currently I'm working in Sydney Local Health District, which is basically spread over an area of about 127,000 square kilometres, but it's packed into the inner part of Sydney. So any population growth around that inner west area is actually a really significant issue for us in terms of planning and facilities. Our population is about 615,000, which by no means makes us the largest local health district in terms of population. But there are 11,000 people who work with us, 11,000 people who could be part of our journey on quality and safety, and we're very keen to involve them all. We have 5 acute hospitals. We have a significant Aboriginal and culturally diverse community, about 1,700, 1,800 beds, about 50 operations per annum. But its focus is also an integration of a high-profile academic research and education centre and a drive towards clinical excellence that brings. The main facility is Royal Prince Alfred. This is the front of the facade of Royal Prince Alfred. Some of you may have visited there or know a little bit about it. It's one of the premier tertiary referral hospitals of Australia. It's known for its liver transplantation service, cystic fibrosis, a whole lot of things that I won't go into the details of it, but it serves a very busy population in the inner west of Sydney. I mentioned our Indigenous population, so we have at Redfern, the Community Health Centre. Redfern is also the site of one of the best Aboriginal medical services in Australia. We're very proud of the work and we work in close partnership with them. And most recently, the Professor Murray Bashir Centre has been built for mental health, again on that central campus, but providing comprehensive mental health services that are community and acute together, which is really the future model for mental health. So that's a little bit about us and where I'm coming from. So just moving on to the face of change. So is our world a changing world? Well, our previous speakers have said that it is. But let's just think about the face of that change, because it's the change we're experiencing now. As said before, the rate of change is increasing, not only in the medical knowledge that we're all expected to learn, but also that we now really understand that we can't possibly carry it all around in our heads. But that change is something that people at different stages of their practice may relate to differently. So when I started, just a few years ago, people would have a heart attack and they'd be in for 6 weeks. And if they were okay the first week, we'd let them sit up in bed. The next week they could sit on a chair. The next week they'd be allowed to have a shower. The next week they could walk down the corridor. The next week they could try a flight of stairs, and the next week they could go home. And what happens now? Okay, if everything goes well, they come into hospital, they have their thrombolysis, and they're taken straight up to the catheter lab. If everything's going well, they're out in 5 days, not 5 weeks, isn't it? So this changes completely all the things that we need to do in comprehensive care, but it also means that our time to actually operate in hospitals has to be affected by how we're working with community services, general practitioners, rehabilitation. Medical technology innovation, radically different. But yet I'm still dealing with people who come to me saying, oh dear, the junior medical staff want to create another app. And I say, yep. And they say, but they've got mobile devices. And I say, yep. Okay, so that kind of technology and how we embrace it for the future, you guys are the ones who know much more about it than people like me, but that's the world we're going to be living in and we've got to be ready for it. At the same time, there are new medical specialties appearing. One of the most recent ones that came across my table was an epileptologist, who's a specialist in epilepsy, but all over the place we're getting new specialties, and we haven't actually recovered from the super specialisation that some of them have caused at the moment. So that phase of providing generalist care, community-based care and increasing specialised workforce is one of our challenges. And then finally, the last one I'll pick out of this is actually community expectations. It's no longer satisfactory to have a paternalistic or a maternalistic attitude to our patients. Our patients are well informed, sometimes not 100% accurately because Dr. Google has limitations, but they increasingly expect to be involved in their care. And that puts a certain flavour on our way that we interact. But in fact, if you look at it reasonably, the things that we think are being said, the way that we communicate, if you listen to your patients, are not necessarily what they're hearing. And there's little subtle differences in that, which I'll come to a little bit further over the page. Okay, and so how do we sustain change in healthcare? Okay, the first thing is there's a lot of talk about how people are trained and educated. Is this happening to you? So we have an apprenticeship model of training, don't we? Where basically we do our apprentice. So hands up the people in the audience who think the apprenticeship model is really good. Okay, who are the people who think it's awful? Okay, so there's a lot of discussion about how we train clinicians of the future. And I would say to you that this is one of the most important things that we need to get into. This is not about education. This is about how we provide clinical practice. And this is directly relevant to future leadership, but it's also directly relevant to clinical excellence. One of the things I'm particularly interested in is in clinical communication. And one of the things that I know when I was taught was I was expected to come out of medical school and have excellent communication skills, and I never needed any development on those because no one ever gave me any. I was expected to be able to deal with difficult discussions. I was expected to be able to deal with colleagues who had different points of view to me. I was expected to know all of those things. But we know there are skills and learning that can be done, and our junior staff are saying to us, I want to be trained in having difficult conversations. I want to learn the difference between being assertive rather than aggressive. These are important issues as we're looking forward. The other thing is resource management, and I am going to talk about this a little bit later. The reality is we have a finite resource. Your time is one of those finite resources. The amount of money we have to spend on health is one of those finite resources. But again, when I look at my own training and my own development, I had absolutely no training in that. I wasn't taught about clinical change, I wasn't taught about clinical redesign. And yet, I can tell you guys, it's fun, because you really get to see some of the things that are important to you in an environment where you've actually moved ahead. But with our fragmentation, with our diversity, sometimes it's true that that way forward can sometimes seem too big, too hard, or it's too far ahead. And I don't know if that affects you, but I know that some of my colleagues sometimes will step back from a change process because of some of those issues. Okay, so clinical governance, the term, we've heard a little bit already about it today, so I'll go over the top of it. There's a couple of just things that I wanted to mention. First of all, it is actually only relatively recently that healthcare issues were recognised as system related, and it's not yet universal. It's actually not going to work to tell somebody who's been involved in an adverse event to just don't do it again and expect that that's going to be the problem. That'll be the problem fixed. Usually, every major adverse event has got a whole lot of things that fell through the cracks, a whole lot of system issues. If we want to really fix the problem, we have to actually take a step back and look at what happened. And when total quality management came in Australia in about the 80s or 90s in health, there was a lot of negativity about how it was so process orientated and so unhealth-like. But the reality is the concept of having clinical teams getting together to look at how things work on their units to try and improve or get rid of rework or frustration is actually core business as far as I'm concerned. So if you want to do some reading about this subject, don't dismiss Deming, no matter what anybody tells you, it is really worthwhile. He revolutionised the world for post-war Japan, post-World War II Japan, and helped it to become the manufacturing experts that they are today. The next thing is clinical leadership. So two of the clinical leaders, some of you may have heard of, Brent James, who's a surgeon from the UK, John Berwick, who's a paediatrician, have taken leading roles. Brent James's particular interest in surgery was that he went to start looking at the data about outcomes and realised there was a whole mine there to be mined of information and skills. And he changed from being a cynic to being a convert who now runs training programs. And if any of you can convince your supervisors, etc., to give you a training program over with Brent James's program, the feedback is it's fantastic. Don Berwick, of course, was a leader of the Institute for Healthcare Improvement, a paediatrician whose heart is put out when he talks about things like saving lives, the effect of quality and safety. And I would go miles to listen to Don Berwick speak, because every time I come away from it, he gives me the sense that we can actually do things. He was the person who Obama put on to try and do a lot of work with the US health system. So obviously he's well respected. In Australia, some of you might be familiar with the Adverse Error Study of 1995. Does anybody know about that study? Okay, it looked at something like 14,000 patient records. It was a group of people who had a look at it. It was one of the first published studies that said that adverse events were having an effect on mortality and morbidity in hospitals. But of course, when it was first published, you can imagine what the headlines in the newspaper were. There are patients killed in hospitals. And that's one of our challenges, is how do we involve the community in realising that we want to talk about this. We need to talk about this, because only if we open up the discussion will we be able to start to get to the bottom of the matters. And then increasing the aviation industries and parallels with the professional environment. Now, a cynic once told me that there is one big difference between aviation industry and health, and that is that the pilot has a vested self-interest in making sure that everything goes smoothly, because he's on the plane too. Possibly true, but when I come, some of you might have strong views about the use of checklists and pathways and things like that. And what I would ask you at this stage is, would any of you get onto an aeroplane if you knew that the pilot and the co-pilot was deciding not to do the pre-flight checklist because they actually knew everything was all right? And I'll just leave it there. Okay, here are some of the great cases. There are so many cases, and unfortunately there continue to be more cases that we can learn from. A mention has already been made about Bristol Infirmary, paediatric cardiac surgery, high mortality rates and excessive operating times. The main thing about Bristol, the sentinel lesson from that was it was one of the first cases where the senior clinical and the senior management leadership of an organisation were held accountable for the clinical culture and the failure to act. And it really radically changed the world, not only in the UK, but in other countries as well. A bit closer to home in Australia, King Edward Memorial Hospital in Western Australia, again a premier tertiary referral hospital for obstetrics and gynaecology, but with heavy workloads, increasing case complexity, and a lot of rapid changes in chief executive, chief medical officer and the leadership of their team. Undergoing clinical service reviews, but developing a culture where people seem to be not comfortable about speaking up for safety and quality. And it led to a major inquiry in 2000. Some of you, I actually went to a meeting in Western Australia, a conference in Western Australia at the time this was happening. And a lot of the other states were really enthusiastic to learn from King Edward Memorial's lessons. But a lot of the Western Australians were very quiet. Because the thing to remember with these incidents is that it's very difficult if you're part of the hospital, part of the staff, who knows all the good things that happen in your hospital, but you're still dealing with a major adverse event. And that's one of the reasons why I say to you, it's really important we learn about how we're going to cope with those things now, because it will be part of your clinical world. In the next 10, 15, 20 years you're working in, someone you know, somebody you trust, somebody you work will be involved in some way in an adverse event. And it's really important to know how you will respond to that and how you will work through it. Okay? Right? Fantastic, all right. Okay, one of the other famous ones is at Bundaberg in Queensland. Has anybody heard about this? Hands, anybody? Okay. All right, so it was another encapsulated case. It was about credentialing and complaints management. And there was a big inquiry, a big report about this, and anyone who was in Queensland at the time of this report, it was on the news, it was in the media, it was everywhere. But the central issues, the summary issues were credentialing and checking a doctor's background is really important. The question of how he was credentialing, his credentialing by peers was very important. At the same time, the hospital budget was under stress and there was a pressure to do waiting lists. So this doctor was actually helping with the waiting list. And the other thing was the lack of a complaints management system, where complaints were seen as opportunities for improvement as opposed to threats to the organisation. So again, that commission has had an enormous effect again in Australia. I could probably give you half a dozen more examples, some more recent, etc. But the reality is a lot of these have common features, and that they are about leadership, management, systems, and the openness and transparency of the culture. So, you've already heard today definitions of clinical governance, and I'm going to give you a slightly different tack. Clinical governance means that clinicians, managers, board members, where you've got boards, are all jointly responsible for the quality of the care provided by their service. And all clinical governance is a framework by which that accountability is demonstrated. And as employees, staff members, patients, etc. of a hospital, we can all have a part, or a health service, we can all have a part in this. There is a shift in the paradigm. Corporate governance is an important function in an organisation. Corporate governance has been about financial management, financial control, audits, etc. And the old paradigm of health used to be a delineation between the management of the business and the management of the professional standards and quality of patient care, which was usually with the medical and nursing staff. But the new paradigm is that this is a joint accountability. It's no longer good enough for the Director of Finance to say, I'm sorry you can't have that life-saving piece of equipment because we don't have the money. Nor is it satisfactory for a clinician to say, don't bother me about money, I'm just here to look after patients. Okay, we're all in this together and we all have a responsibility to manage together, and we can do this because the features come together. If an organisation recognises and accepts they've got joint accountability, they'll talk to each other, they'll work together, etc. If the environment promotes and fosters quality of care and safe practice, then people will bring their concerns up, they will talk about it with their colleagues. Their colleagues may guide them to the people who can help them. If we partner with our community, our clinicians and our patients, we will actually know what's going on. Because as I said, patients sometimes hear what we're saying in a different way. And some of you may have heard the comment, the one of your patients said, look, I didn't want to bother you because I know you're really busy. And yet it was something that was really important and you needed to know. Because we are really busy and our patients really have a high level of respect for their clinician. We also need systems to monitor, identify and report on the quality of care, systems where that information that's presented is not seen as being critical or personal. And incident reporting systems are probably the ones that you're most familiar with. Could I just ask, do you have a root cause analysis and incident management process in New Zealand? So root cause analysis is the same term, because there is a bit of variation. So those particular processes are not designed to find whose fault it was and tell them not to do it again. Those processes are designed to find what are the system issues to make sure it never happens again. Okay, that's what they're designed to do. And then effective mechanisms that minimise harm or clinical risk. And Paul, I think you talked about that a bit earlier. Risk management is, again, not about finding blame, not about making things up just to fill in the risk register. It's about saying, okay, there genuinely is a risk that this isn't going to work, and these are the kinds of things that we can do to mitigate the risk. And we don't have to get rid of risks in health. We just have to mitigate them, because some risks will always be with us. Okay, there will always be a risk somewhere, but we've got to mitigate it. Okay, so a little bit about Australia. We are quite structured in Australia, or the structures go under change. We have an Australian Commission on Safety and Quality in Healthcare that was established in 2006. Its role is to coordinate safety and improvements across the country. It's a corporate Commonwealth entity. It's governed by legislation. It's jointly funded by all the states and territories as well as the Commonwealth, and it has a board that's appointed by the Commonwealth Minister of Health. But its main interests are things that impact on us on a day-to-day basis. It's one of the drivers for national standards and accreditation in safety and quality. So who's been involved in any teams looking at national standards or quality and safety standards accreditation? There's a few hands. Okay, now increasingly these standards are getting straight onto the stuff that is important to us. Things like blood transfusion, clinical handover, infection prevention and control, medication management. They're the kinds of things that are coming up in the standards. I'm a fan of accreditation, partly because I think accreditation encourages people to do the right thing. I do think we can make the process a little bit more smoothly by focusing on these things all the time and not in the 2 weeks before the accreditors arrive. But basically, if you think about what the difference, if I think about the difference in the Australian health system since accreditation and national standards were developed, we are making gains, there's no doubt about it. The Commission's also looking at how it actually can show us what's happening across with certain complications and patient experience across the country, because it's actually really helpful for New South Welshmen to know what's going on in Victoria and Queensland. And one of their recent publications, which is available on the internet, is the Australian Atlas of Healthcare Variation, which a colleague of mine has had a lot to do with the development of. And it shows you the numbers of differences of patterns across Australia in simple procedures. Admission rates, mortality rates, length of stay, etc. There's a lot of difference. And not all of that is explained by clinical practice. So it's a very interesting document. It's a bit of a controversial document, but I recommend it to you. The Commission was one of the first to give us an Australian Charter for Healthcare Rights for Patients and Consumers, which was an excellent brochure developed with the community. And one of its most recent areas, which may be of interest to somebody down the back, is that they're actually being given the task of looking at a national antimicrobial resistance surveillance system and how that might be implemented in a meaningful way in clinical practice. If we move to states and territories, there are different models across the states. Queensland Health has just established a clinical excellence division within its structure that incorporates patient safety and quality improvement, who's led by one of the leaders of quality and safety in Queensland. Victoria's had another series of adverse events associated with some, I won't use the right word, but deaths of babies in a place called Bacchus Marsh, a little place in the country. So there's currently a review going on led by Professor Stephen Duckett into looking at ways of how they're going to strengthen their governance and approach to quality and safety. And in New South Wales, we have the Clinical Excellence Commission, which is one of the pillars that support the LHDs in New South Wales health system in addition to the ministry. And the Clinical Excellence Commission was launched in August 2014 as part of a revamp. Its first chief executive was a guy by, he may not have been the acting one, but he was a cardiothoracic surgeon from Prince Alfred, my current hospital, Professor Cliff Hughes, an outstanding clinical leader and an outstanding speaker-upper for improvements in practice. And under his leadership, it became quite a force in our practice. Its programs included the introduction of the Between the Flags program, which is management of the deteriorating patient, put together by clinicians with training programs that clinicians thought were the appropriate things to learn, with tools that were developed in conjunction with the clinical staff. And that came from looking at our incidents and reading what incidents were occurring across the system. The need for something about detecting the deteriorating patient actually came from there. So it was a success of the CSC. The other thing was open disclosure training. So open disclosure about the transparency of talking to a patient or their family sometimes after an adverse event. So again, the training program for that was put together by the CSC, locally delivered in the local health districts, etc. So the CSC on the whole is seen as being a great supporting pillar, or in this particular period of time has been in the past a great supporting factor in LHDs. As far as the local health districts, the board clearly has responsibilities for quality of care. It's in the service agreement. Most LHDs have a quality council as a subcommittee of a board. There's the role of clinical governance director, who's a member of the executive, and in most organisations reports directly to the chief executive, and I had the great privilege of being the director of clinical governance in Hunter New England Health for 5 years. And most outstanding organisation, and we did some really great things. Their role also is to provide executive liaison with the Clinical Excellence Commission, and they meet monthly with the Clinical Excellence Commission. And they also oversee the various different legislative requirements, including those for incident management. And depending where you are, this is the breadth of things that clinical governance units can do. Some of them may have responsibility just for incident management, complaints management and patient surveys, but others are getting into the dynamic leading edge stuff, like new interventional procedures, quality improvement, clinical redesign, various different issues. But there in the slides is basically a semi-comprehensive list of some of the things that might be considered. So, culture, environment, etc. This is a slide I usually use for teaching the Newcastle University medical students when I did it, but I've put it in here and I've borrowed it from a colleague because I want you to take a second to think about culture and think about what developed your views of culture in health before you started to practice. So was it this, or this, for the older people, or that, or that, or that, or perhaps that? Okay, so our views on culture and the way we're trained, we're not taught about culture when we go through medical school, and I doubt that our nursing and allied health colleagues are too. But the reality is culture is in our own hands. I had the privilege when I was an intern and registrar working with a group of colleagues at a hospital where we all worked together and we looked after each other and we helped each other, and our consultants spoke to us, and if we had problems we could talk to medical administration. That was the way I grew up, and I can tell you that was a happy hospital. It's true that hospitals and health services can go in cycles. As we've heard before, the leadership at the top has a lot of influence on the culture of the organisation, but it's not the only influence. The leadership in the clinical areas is actually really strong, and the clinicians are often there for a lot longer than the managers are, so don't lose heart. There's always something you can do, because here's what health professionals are to me. Okay, and yes, I may be Pollyanna, but this is what I work with, these are the people I work with. Motivated to do the best they can, trained to look at data and think scientifically. They actually like the intellectual challenge usually, and they'll debate readily. Sometimes even if they don't actually agree with it, they'll take the other side. We're taught to prize our clinical autonomy and in fact put into situations where we have to exercise that. We respect expertise, we value its acknowledgement of our own expertise, and we really tend to disengage if our time's being wasted, don't we? And that's probably one of the biggest challenges to clinician engagement, is to work out how to best use the time of busy people like you in meetings, etc. The other thing is we tend to be very risk adverse, and sometimes some of the discussions that will go on is because of that desire to eliminate every risk from the patient situation. So there are some of the things. Does that ring true with you? Are they the kinds of people you're working with? Okay, so what are the success factors for managing hospitals? Well, on the whole, successful hospitals and health services are well managed, clinically as well as managerially, which means clinicians and managers get together to run the place. The leadership team is visible. You would know who your chief executive is, who your medical director is, who your director of nursing is, and you might even know who the finance director is. Those kinds of things will be highly visible. Innovation is seen as a necessity, but innovation, of course, is evidence-based. I'm going to try and come to that in a moment. But there's an explicit decision to invest time in quality, culture, communication, values and teamwork. And we heard from Bupa today their investment in values. When I worked in Hunter New England Health, one of our biggest tasks was to communicate our values to a health service that consisted of two area health services who'd been brought together in a restructure who didn't like each other very much. And when it came time for the next restructure and they were separated, the clinicians said, don't leave us apart. And if ever you want to know that you've been successful, that's the kind of thing that marks success. And then the other thing is the decision-making framework, because you can't work without it. The other thing is the environment to support quality and safety. Some of these words may be familiar to you. At one stage we were talking about a no-blame culture, where if something went wrong we had to be very careful not to blame anybody. Then the next thing was a beyond blame culture, which is to say, well, every now and then, yes, well, we just need to make sure that we're not just focusing on blame, that we're actually going beyond that. But now it's much more about a just culture, which means that the system issues and the reviews of the system issues have to be associated with accountability and responsibility. Now, in my experience, people involved in adverse events can go two different ways. Sometimes they're so horrified about what their involvement may or may not have been in the incident that there's nothing you can say or do that isn't worse than what they're doing to themselves, and you find yourself in the other direction. But for those without insight, for those people who continually refuse to wash their hands, continually refuse to flout policies, what do we do? Because if we tolerate it, we accept it. Okay, we promote it because we're not standing by the policies and things that we say. So the just culture is about accountability and responsibility, but focusing on the system issues and not thinking it's just about telling that one person not to do it again and everything will be all right. Okay, the other thing is the environment we work in. The culture in Australia now is you say, hello, how are you today? Oh, I've been really busy. Okay? All our measures and everything like that are about how busy we are. But busyness itself can be a danger, because keeping busy sometimes means that we're not taking a step back to think about what we can do. I've talked about the finite resources, but we haven't spoken about relationships, and the relationships are really important. The world that we work in is a very small world, I find. There's already people here in the room today who I didn't expect to see, but I know from previous interactions and relationships. Unfortunately, they're positive ones, so that's okay. But those relationships you take with you and carry into the future. You may have a particularly warm feeling about the people you went to medical school with. You might have a particularly warm feeling about your first placement, but you're going to have that particular warm feeling as you go through your careers as well, because those relationships are the things that will help you to make change. And of course, in health, we do have this culture of patient safety and service. Most people don't go into medicine these days to make a lot of money. They go into it because they want to add to the community. So positioning for the future, I might just skip that because I want to get to this. I wanted to talk about the leadership paradigm, just briefly, because everybody talks about leadership. Now, there's a guy called Cotter who writes very easy books to read. In fact, I give all my trainees copies of these books because I think they're good to read. Cotter says, leaders don't make plans. They don't even solve the problems. Leaders don't even organise people. What leaders are really doing is preparing organisations and people for change and helping them to cope as they struggle through it. Now, I know that's a slightly different tack on what you may have been told before, but one of the issues is moving organisations and people through change takes a lot of talking and a lot of time, because even the person who seems to be resistant to change may actually have a reason that you need to know about why they don't want to change. Now, accompanying to that is the style of management. So management is about coping with complexity, bringing a degree of organisation and consistency to outputs and qualities. And leadership is more about coping with the change. There's no leader I know that isn't reliant on good managers surrounding them, good people who will help them to implement, good people who will work in those systems. And that's one of the things I find is really important in my role as clinical leaders. They tend to be very time poor, but we can't make the changes without their input. So one of the things that management role can be is to make those meetings run smoothly, make sure the data's there, to make sure that we're answering the questions that the leaders think need to be answered. So please, as you develop your careers, think well of managers. Just because they're not called a clinical leader, they're a clinical manager, they're actually really important to your world. And think about what it means for an organisation to change. We need the vision, we've heard that already. There needs to be a sense of direction and a chance that we can get there. Consultation can be enormous when you're making a massive change because it impacts on so many people. Engagement, we've talked about briefly, we'll come back to it, but champions, people who will stand up with their colleagues and say, look, you know, that's a good point, but I don't see it like that way. And when we were trying to bring our communication tools in, one of the challenges I had with some clinical staff where they're saying to me, oh, you know, communication goes really well on my ward round, I don't know what you're worried about, Kim. And so I tell them the story of the phone call somebody had got the other day where this is a big diverse health service. They had a phone call from somebody from one of the emergency departments, didn't introduce themselves, obviously really anxious about the patient they were caring for. At the end of the conversation, they said, look, I think you do realise that I'm the anaesthetist on call. I'm not the cardiologist on call. They'd run the wrong person. Then all of a sudden, my colleagues all had stories that they could tell about telephone calls that have gone wrong and that kind of thing. So it's amazing how telling stories will create the champions for you. People who think their systems are perfect or who are involved in an adverse event can be the greatest champions in the world because they actually want to share their experiences with their colleagues. They will model, they will motivate, and then the reinforcement and integration is really important. So Cotter's steps. So I'll just spend the next 15 minutes on leading edge issues in clinical governance. Now, if I put this in front of a group of medical directors and nursing directors, etc., I'm sure they'll come up with a different list. But here's my list at the moment. The kinds of things that we are constantly struggling with are governance, systems, organisational cultures. And I guess that's why you've got somebody from Bupa and someone from Australia coming to talk to you today, because we're all trying to work out how to do this. The next thing is clinical practice excellence and improvement. Okay, we are struggling with this. We know that not everything has an evidence base, but even when there is an evidence base for everything, the evidence isn't always followed. But getting that through and changing that is not a simple thing. Patient safety and incident management I am going to talk about. The involvement of patients and consumers is really essential. If your patient's really worried about getting home because of some major family event that's coming up that they haven't told you about, it can actually affect the way that they're having their care in hospital because they're more worried about home than getting well. And it's really easy to find that kind of thing out if you listen, isn't it? Now, maybe some of you have never had that experience, I know I have, and sometimes the things that have worried the patients can actually be fixed really quickly by involving social work, involving other people, or perhaps making special arrangements for that special day. The other thing is reward and recognition. So we do recognise clinical excellence. What about recognising quality excellence? So has anybody in the room ever had a project that they did put up for a quality award? Fantastic. Okay, please share those ideas because it really reinforces good practice. So the Australian Council on Healthcare Standards used to give a small amount of money to medical students and junior years for quality projects that had changed something in their department. And the enthusiasm, it wasn't an astronomical amount of money, I think the certificate was more important to them. But they presented to grand rounds. They presented their cases to grand rounds. And that recognition of what they were done, I can tell you, it made a really big difference. So let's talk about patient safety. The Clinicians Toolkit, which is a New South Wales publication signed by the Chairman of the New South Wales Division of Branch of Surgery at the College of Surgeons, is an excellent document, not really in print at the moment, but you can get it on the internet. And it shows you the range of quality and safety tools in the clinicians' area. But it talks about incidents as being unplanned events associated with injury, ill health, damage or loss, but also near misses. And there is some literature that suggests that if we actually spent more time looking at the near misses, which are harder to track, we'd have more of an impact on our health rather than just looking at the major incidents that occur. Although I don't think they're actually suggesting we don't look at the incidents. So if we're going to have robust incident systems, and remember a lot of those sentinel events that I told you about earlier in the antecedents were actually lacking some of these features. Robust systems for reporting incidents and complaints, clear mechanisms for investigating it, the promotion of the review of the incidents and complaints as a positive quality improvement exercise, and also more recently the issue of feedback mechanisms to the person who's reported the event or been involved in the event is becoming a bit of a gap in our systems. There's no doubt if you want people to report incidents, giving them feedback about what happened last time they reported will work. So there is a New South Wales health policy on how we're supposed to manage it, and it sounds like you have one too. But there's also a statewide incident management system which can show us trends and patterns that you may not see in your local health district. And one of the case studies I just want to give to you is basically something that really brought this home to me a few years ago, where a doctor who was an anaesthetist was reporting a drug reaction experienced by a patient. And she got so cranky about it, she put it into the incident database, but she also told the clinical governance team about it. And so they went into the database and found out that there are actually similar incidents being reported elsewhere. And so the matter was elevated and had a look at it, and it turned out that there was actually a batch issue identified, and in fact it promoted a system-wide recall. So those incidents can actually have quite far-ranging things. It's not only about what happens in your own organisation that can change things, it's about the impact in the system. Okay, can I move on? Clinical effectiveness. Now this has been touched on today, but I just want to go a little bit further into it. So first of all, let's define it. Another excellent publication of New South Wales, I think I'm doing a promoting for their publishing ranks, is the Quality for Management, Framework for Managing the Quality. See, 1999. That's a long time ago now. But it's still one of the best documents on quality and safety I think that's ever been published. And it talks about 6 dimensions of care: safety, effectiveness, appropriateness, consumer participation, access, and efficiency. Okay, so effectiveness is about whether or not the treatment received by somebody produces a measurable benefit. So it relates to the extent in which the treatment, intervention or service actually has the desired outcome. Now it's a bit different to appropriateness, because appropriateness is whether you did the right thing in the first place. Effectiveness is whether it worked. That's probably the simplest way of defining it. And efficiency is about doing things right. Effectiveness is about doing the right things, but there's nothing useless as doing efficiently that doesn't actually need to be done at all. Okay, fair enough? So do you think we do things that don't need to be done, even if we do them really efficiently? Okay, so this is what clinical effectiveness is about. Okay, so it has a sound basis to clinical decision making. It should be evidence as the basis of supporting any innovation. It's about clinical review, it's about guidelines, but it's also about an environment that will take things into clinical audit and systems as well. So believe it or not new again. So the first expert in audit and effectiveness was Florence Nightingale. So a fascinating lady back in the Crimea War, which is a little bit before I was there, 1854. So again, her story is one of poor levels of hygiene associated with high mortality rates in soldiers. She had a mathematician's background, so she started to analyse the data about mortality rates. And what she found out was that soldiers were 7 times more likely to die due to disease in the hospital than they were if they were left out in the battlefield. Okay, so she changed the way things were done following the discovery. She improved hygiene on the wards, and within a year, mortality rates had reduced from 60% to 42%. And this is before antibiotics, don't forget. So with continued work, the rates got even lower when she started using fresh, clean water and introduction of fresh fruit and vegetables in patient diets. So there you are, 1854, this is when it all started. There are some risks to clinical effectiveness, of course, in our environment. Possibly our data systems and our support for this is not as good as it could be. There's still a lot of paper that's being used and a lot of people entering things into standalone data sets and databases. A lot of the M&M meetings that I've been to over the time, and maybe it's different in New Zealand, there's often a lot of focus on an interesting or an unusual case that's the longest discussion in the mortality and morbidity review. I'm not saying that's not important, because recognising those is important, but there's also the routine things that need to be reviewed. It tends to be something that gets fitted in, so registrars, junior medical staff can have a pivotal role, but it tends to be done in addition to their usual duties. There's sometimes legal and legislative paradigms that can become a bit concerning should we look at these things. And it's not always easy to determine the sound evidence base of some of our clinical decisions, as well as the ones that we do things where it isn't there. So, but here are some of the things you'll be familiar with a clinical effectiveness program. Clinical audit. All deaths are reviewed. Are all deaths reviewed in New Zealand as well? Okay, so all deaths are reviewed. The ones that look like they are due to adverse events, then they're subjected to another course of review. There's a system of flags or criteria for clinical audit. It varies from place to place. In Victoria, they had a run-in using a system of flagging certain things that they wanted to look like VTE, medications and things like that. So that's another way of doing it. Clinical indicator systems such as are used fairly widely, and then learning environments such as journal club, research, grand rounds. But again, we've been on this journey for a while. So Sir William Osler, one of the fathers of medicine, in seeking absolute truth, we're still aiming at the unattainable, and we're still content with our broken portions, but I'm on a campaign to start connecting them a bit. So clinical audit is a practical approach. Okay, mortality morbidity review, routine regular review of deaths and clinical outcomes for a defined group. Peer review, a comparison of one's own practice to those peers also occurs. So in my college, which is the College of Medical Administrators, okay, you might think, what are we doing? Well, we're now required to present ourselves for peer review on a regular basis. And if it isn't already the same for all the other colleges, I'd be very surprised if it isn't. It's going to come in the next few years. This should not be a threatening circumstance. The idea of this is to be able to say, this is what I think is happening, these are my results, and to get feedback from peers. But how we conduct ourselves in peer review can have, of course, a large impact on our culture. The other thing is it does require preparation and has been traditionally the role of registrars in training, but I think that's developing a little bit more. Sometimes I think it's easier in the bigger hospitals where there tends to be infrastructure and research and other activities, a little bit more difficult for those people who are in rural or remote practice, but we can change that. Just to mention, one of the things also is that there's a number of statewide review processes. So there's now a surgical mortality review under something called CASM, which I've put down as an acronym, my apologies. But basically where surgeons can report their cases, or any patient that dies is reported into the Clinical Excellence Commission and reviewed by peers. And the feedback goes to the clinician. It doesn't necessarily go back to the hospital, but it goes back to the clinician. And there's two levels of peer review. The first one is to say whether or not it needs to be looked at in detail, and then a high level of specialist review. So it's modelled on Western Australia, and in fact I think on Scottish programs in the past. And then places like anaesthesia and maternal and perinatal committees, which I suspect exist everywhere, basically are looking at deaths as well. So the leading edge of clinical engagement, here's some thoughts about your world. Busy roles, rotations every few months, does that still happen? Trying to find the people who are like-minded, who may not be other doctors, they might be nurses, allied health, or in fact managers. The multidisciplinary teamwork can be challenging when you're only getting to know everybody for the first time and trying to work out where they are coming from. And then the urgent and the immediate overtaking the strategic. But here's some examples that I could think of that I thought might be of interest to you. The first thing to say is that this is now part of your clinical life, not just now, but it's going to be in the future. And I expect this is going to be a great part of your life in the future. At the very early stage, we started putting interns on incident review teams. A lot of people told me that wasn't the right thing to do, but we did it anyway. They all had to do one RCA process during their internship, and the result of that is that we had interns coming and asking whether they could do another one. So it actually was a very positive experience seeing it firsthand. At Prince Alfred, there's an RMO's Innovations Committee that's actually linked to the medical executive that raises particular points or questions that they think need to be looked at and get some support in looking at them. And they've become the initiators of some clinical practice improvement, for example, looking at discharge summary content. As we're moving on to the electronic medical record, they're also working on that as well. And then the other thing I mentioned earlier was communication skills and leadership skills training. It should be defined by you. Okay, you should be providing feedback into that so the training fits. Unfortunately, I'm not going to have time to talk about clinical innovation. other than to say innovation is absolutely essential, because if we don't innovate, we will die. But there actually is a structure and a way of doing that, and I'd be happy to talk to any of you about it, because really there is a way to safely innovate and safely introduce new innovations with risk minimisation. Now I've got the 5 minute chat, so I can't really spend too much time. I'm not a great believer in the clinical efficiency argument as a raison d'etre, but I just wanted to reinforce what's been said by other speakers. We have a lot of waste and rework in our world, and a lot of that rework can actually be really frustrating. When we cancel somebody on the day of elective surgery, there's no win for anybody, including the patient. Someone has to tell the patient, someone has to rebook them, chances are you're losing operating theatre time, there's a whole lot of issues and challenges there. So please don't dismiss this argument of efficiency, because it's all about money. It's actually about time, it's actually about resources. And managing length of stay is really important, and we have a project going on in Prince Alfred at the moment about criteria-led discharge. We're actually trying to make sure that as soon as patients are clinically ready to go home, we've got all the functional and social supports in place for them to do so that they can go on that day, and that we don't leave it to the day they're going home to say, oops, we forgot to get the physiotherapist involved. So there's a growing clinical leadership in that area, but that's just one of many different programs and projects that can be involved. So I'll skip through that. Okay, so the final couple of comments, potential ways to be involved. These are my views, and I'm making them in good faith. You may agree or disagree with them, but what I was trying to do is work out how to be successful. So I think there is increasing understanding that everybody should be involved in improvement. It's not just somebody else's job or the quality unit's job. And I'm sure that there are going to be existing opportunities everywhere, whether it's just putting your hand up about clinical audit or incident review and making yourself visible. Okay, and interested. Honestly, it does make a difference, because if someone volunteers, you know they're interested. But think of the influence and decision-making in your organisation. There's an interesting interface in clinical practice between formal and informal channels of influence. Not everybody who's the head of department is the person who has all the influence. And in fact, there's many clinicians in different roles who are leaders in various different areas. And you may just... They are people to get to know, etc. And some of you are actually in the room from the questions that I heard in the first round. It's important to understand that difference between influencing the agenda and being the line manager. The other thing is negotiating skills, the getting to yes. So there's a book called Getting to Yes, and it talks about how to get across the negotiation part of one's life. So again, negotiation skills were not taught to us, okay? But the importance of separating the people from the problem. So even though somebody might be difficult, look at the problem, not the person. Focusing on the interests and not their position. Yes, that might be a nursing perspective, but not every nurse feels exactly the same way about something. Looking at options for mutual gain and insisting that any review process has objective criteria. All of these are good messages about moving a no from a yes. And then for building relationships, because honestly, this is so much about building relationships. Delivering on promises. If you say you're going to do something, do it. Listen, really listen, and listen, and listen, and listen. It was one of the most important lessons I learned. No matter how frustrating something is, listen. Keep the communication flowing. If someone hasn't got back to you on an email, well then, ring them up, find them in the ward, go down to theatre. There's differences in the professional groups and their frustrations, but wasting our time is one of our biggest full pots. When people give you advice, listen to it. Give them feedback. You don't have to agree with everything that's said, but if someone gives you advice, it's a gift to be received. And I think it's really important to treat the past with respect. That's different to living in the past, but there is a reason why some things are the way they are. And what's the old saying? Those people who dismiss history are doomed to repeat it. It's the same in our organisations with their tradition, their culture, and the people who are sometimes given 30 and 40 years of their life to service to the organisation. So in closing, clinical governance is a mandatory part of LHD structures in Australia, and it's as important as fiscal accountability, or I think it is anyway. So understanding of quality is a key driver. So we have activity-based funding now in Australia as an example of efficiency, but it's actually a matter of quality care, not just efficiency. We do have state and national initiatives that are helping us to build capacity, but we also look overseas. We look here, we look to the UK, we look to the US. Clinical leader engagement, there's a whole different discussion. There's actually groups looking at clinical leadership in different forums, and we don't have time to talk about it now, but putting your hands up is really important. And I think resident medical staff are the way to go. You've got so many different opportunities. They're lifelong skills. Find the people with common views. They could be your supervisors, they could be the medical director, they could be the clinical directors of the area, and establish those relationships. Treat clinical governance like my favourite little lemming at the back. It's actually a lifelong skill and it'll help you to swim as you jump off the cliff. And then again, it's already been said, Albert Einstein, one of the greatest quotas of all times, learn from yesterday, live for today, hope for tomorrow. The important thing is not to stop questioning. Thank you.